Hello everyone, and welcome to this month's Children's Nursing Development Unit Journal Club. I'm your host, Fatima Ibrahim, a research officer, and I'm thrilled to share with you a truly fascinating study today. This research comes from right here in South Africa and explores something you all do every day, working with mothers to care for their hospitalized children. But this study reveals practices that might challenge how you think about family involvement in pediatric care. So let's dive in. The article is titled Distinctive Nursing Practices in Working with Mothers to Care for Hospitalized Children at a District Hospital in KwaZulu-Natal, South Africa. It was written by North et al. And published in the journal BMC Nursing in 2020. Today's article takes us to a district hospital in rural KwaZulu-Natal. The authors set out to describe something remarkable, nursing practices that actively facilitate mothers' presence and involvement in their children's hospital care. Now you might be thinking, don't we all work with families? Yes, but here's what makes this so special. This study documents a deliberate, formalized approach that differs from Western models like family-centered care. Instead of just allowing mothers to visit, this hospital makes mothers' continuous presence the norm. So let's explore how they discovered this. The researchers used a qualitative case study design, perfect for understanding practices in their natural context. They worked in a 22-bedded pediatric ward in a remote rural area of northern KwaZulu-Natal. Think about this context. This is a district hospital serving communities where mothers might travel over 100 kilometers to reach care, similar to other parts in Africa. And the data collection was intensive. They had 3 full days of observations and interviews. But more importantly, they followed rigorous reporting standards, the SRQR guidelines, ensuring quality and transparency. So here's what makes this study so rich. They observed all 20 nurses working on the ward and 22 mother-child pairs, essentially capturing the full picture of practice during that time. But the methods are what's really exciting. They didn't just interview people, they used visual methods, things like photographs, sociograms, and something called graphic facilitation, where they drew out care pathways together with nurses. So why does this matter? Because sometimes we can't fully articulate what we do until we see it visualized. And so these methods help nurses describe both their explicit practices, what they openly do, and their implicit values, the deeper why behind their actions. The analysis was thorough and rigorous. The research team used content analysis, working through all the interview and focus group transcripts. They didn't work in isolation. Every piece of data was coded by 2 researchers independently, and when they disagreed, they discussed it until they reached consensus. This reduced individual bias. They also used member checking, going back to nurses to say, is this what you meant? Did we understand you correctly? This collaborative approach strengthened the trustworthiness of their findings. The researchers identified 6 powerful themes that together paint a picture of what they call a care through family approach. These aren't random observations. They're interconnected practices that form a coherent system, from preserving the mother-child bond to trusting mothers as capable partners. This hospital has developed something quite special. Let's look at each theme more closely, because each one holds lessons for your own practice. Here's the foundation of everything. This hospital doesn't just allow mothers to stay, they actively create conditions that keep the mother-child pair together. In 2005, the ward manager proposed replacing small cot beds with 18 full-sized adult beds. Why? Just so mothers could co-sleep with their children just like they would at home. And it's not just about beds. Mothers received 3 meals daily at no cost, hospital clothing and all the supplies they needed. Compare this to another mother story in the study, who at a different hospital said she slept on a coffee table for 3 weeks because policy said that only children could use the beds. Here, nurses said, if the child is alone, they cry, they do not eat. It is easier to heal faster with a mother. They understand that healing happens best when that fundamental bond remains intact. This isn't informal tolerance, it's formalized policy. The ward has written policies stating mothers should stay continuously with children under 10. They even have different visiting policies than the rest of the hospital to promote unrestricted family access. In practice, mothers continue their role as primary caregivers without interruption. They bath their children, feed them, comfort them, encourage medication taking, everything they normally do, adapted to the hospital setting now. Nurses step in only when the mothers are absent. And so this flips the usual script where nurses are primary caregivers and families are visitors. Here the mothers are the constants and the nurses support them. Nurses in this ward demonstrate profound trust in the mothers. They expect mothers to tube feed their babies after minimal instruction. They trust mothers to observe and report clinical changes, to assist with physiotherapy, and even to give medications. One researcher noted watching a mother casually tube feeding her baby, completely comfortable and confident. The nurse said, "Yes, that's normal here." Now, this isn't abandonment. Nurses maintain oversight. They supervise, they check, but their starting assumption is that mothers are capable. One nurse explained that giving medication is so much easier with the mothers present because the mother knows how to make their child take medication. So it is working for all of us. This mutual benefit, better for children, better for mothers, and better for nurses, is key. Here is where we see the heart of this practice. Nurses genuinely care for the mothers, not just tolerating them. Mothers were served meals courteously, treated with respect in every interaction. The ward had minimal rigid routines, so mothers could rest when needed. And the researchers even observed mothers napping in the middle of the day. Nurses noticed when mothers came without their chronic medications and arranged for doctors to prescribe them. They screened for social problems and connected mothers with social workers. So by caring for mothers' physical, emotional, and social needs, nurses enabled mothers to be fully present, mentally and emotionally for their children. When we care for the mother, we ultimately care for the child. It might sound pragmatic. Nurses spontaneously described mothers as essential resources. Mothers feed children while nurses are busy with doctors. They provide the kind of continuous monitoring nurses can't sustain. During procedures, mothers hold, comfort, and reassure their children. One observation described a mother consoling her child during a burn dressing change and then immediately breastfeeding afterwards. The baby settled instantly. But here's the unexpected gift. Mothers also become resources for each other. They pour juice for other children, past crutches, shared experiences. Nurses recognized this and encouraged it, knowing that peer support was valuable. Because 22 mothers are present and creating a community of care, it was rare to hear a child crying in this ward. Final theme shows that knowledge flows both ways. This isn't just nurses teaching mothers, it's genuine exchange. Nurses teach mothers about their child diagnosis, how to prepare oral rehydration solution, infection prevention. They do this there and then, responding to opportunities as they arise. Educational posters in local language reinforces the messages, but equally important, nurses learn from mothers. Mothers report how their child ate, what their diapers looked like. In gastroenteritis cases, nurses asked mothers to show them nappy contents, and mothers became skilled observers and reporters. One nurse said, "The mother must see whatever we do and must master the care that she would even be able to continue at home." And so the goal is mothers going home with enhanced capability to care for their children. So in conclusion, we learned that intention matters. This hospital didn't just allow mothers to stay, they made it a policy and invested resources. Secondly, their trust is transformative. When we truly believe mothers are capable, we delegate appropriately while maintaining oversight. Thirdly, we must care for the whole family unit, mother and child together. And fourth, local context drives innovation. These nurses responded creatively to their rural reality. Finally, describing and documenting our practice gives them legitimacy. So their work was invisible until researchers helped articulate it. Now it's published, shared, and inspiring others. I have 3 questions for you to reflect on. First, look around your own ward. What helps mothers stay with their children and what gets in the way? Are there policies that limit presence? Do you have facilities that enable mothers to stay comfortably? Be honest about the barriers. Second, think about recent interaction with a mother. Did you view her as someone who needed permission to be involved or really as a capable partner? This is really about mindset. The nurses in this study started with an assumption of capability. So how might that shift in thinking change your daily interactions with mothers? Thirdly, what would care through family look like in your setting? Maybe you can't provide full beds or meals, but what could you do? Could you change a visiting policy? Could you teach mothers skills? Could you trust mothers with more responsibility? These questions aren't easy, so take time to discuss them with your colleagues. Thank you for engaging with this important research. I hope the study has challenged your thinking and inspired you to reflect on your practice. Happy learning!